First of all, welcome everyone, and thanks, Shannon, for inviting me to speak today. So what I'd like to do is give some background about our telemedicine program, kind of how we got into that space, and then at the end, talk about our work in the jails, and what we're doing right now. So you can go to the next slide. So just to give you a little bit of my background, I'm a psychiatrist. I've worked at the University of Maryland School of Medicine for the last, I hate to say it, but it's been over 30 years now. I always say, how did I become the old guy in the crowd? But got a lot of experience working in urban areas. And over the last 8, 9 years, we've become more engaged in working in some of the rural areas of Maryland as well. A lot of this, I'm sure you've seen these slides over and over, but we're in the midst of a crisis that's been going on since the 1990s. Opioid overdose deaths have just skyrocketed, and the numbers are just staggering. You can read through those yourself, but we had over 100,000 deaths in the past year, close to 200 deaths per day. And what we've seen in the last 25 years is a significant increase in rural overdose deaths. Basically, opioid use disorder used to be predominantly an urban phenomena. There wasn't access to opioids in rural areas before the overprescribing of opioids. That generally opioids would come into this country through drug cartels into the urban areas and be sold through drug dealers. Now we're seeing, the internet and being able to deliver small quantities of fentanyl to small places throughout the country. So, and that has significance for treatment, as I'll say in a minute. So here again is sort of a timeline of what's been going on with the opioid overdose crisis. It started with over prescribing of prescription opioids. Then we had a surge in cheap, plentiful heroin. And what we're seeing now is this explosion of synthetic opioids that are being coming from China through Mexico. The precursors are being created in China. A lot of it's being transported through Mexico to the United States. And it's synthetic fentanyls or synthetic opioids, variants of fentanyls that are highly, highly toxic and lethal, 50 to 100 times more potent than heroin. So any time somebody uses these drugs, they're at risk of dying of an overdose. One of the issues is that it's contaminated the whole illicit drug supply. So it's not just using heroin or dope, which is sometimes a nickname for opioids, but it could be in individuals' cocaine or other drugs as well. Here's just a kind of a layout of the opioid overdose death rates. This is a little bit old, 2018, but it hasn't changed a lot. You can see the Rust Belt has been heavily impacted. Maryland, unfortunately, is right in the midst of this. I think between Baltimore and some of our rural areas, we have extremely high rates of deaths as well. Northeast has also been heavily impacted. It's just some rural demographics. Rural areas have a lot of land and not a lot of people. 10% of our population live in totally rural counties, and you can see that generally people that are live in rural counties tend to be older, less likely to have a college degree, and have lower poverty rates, but higher rates of chronic pain. A lot of what is happening in rural areas is related not only to an increase in accessibility of illicit opioids, but also sort of a decline in economic prosperity. The rural areas really reached their economic peak in the 1970s when we had there were strong unions, a lot of rural manufacturing, and with globalization, mechanization, a lot of jobs have been lost, and it's really impacted Caucasians without college degrees that have seen a worsening labor market. And we've seen this triad of increased suicides, overdoses, and alcoholic liver disease. And as a result, we have actually seen declines in our life expectancy in the United States, which is not being seen in any other industrial country in the world. And a lot of this is related to our overdose crisis, in addition to COVID more recently. If you're interested in reading more about this, you can look up Case and Deaton, and they wrote a very nice paper, several papers about this topic. I have medication-assisted treatment there. That's not the term we're using now, but Michael Botticelli used in the days that he was talking about this in 2014, which is almost 10 years ago. He was President Obama's drug czar, and we're using the term medications for opioid use disorder now, MOUD. But he basically, even at that time, was saying access to these type of treatments can make the difference between life and death. So there are 3 medications for opioid use disorder that are FDA approved in this country. One is methadone, which has been in use since about 1970, buprenorphine, which many of you know as Suboxone, which was approved in 2000 and has really been utilized since about 2002, and now Trexone, which also comes in a monthly shot called Vivitrol. The first 2, methadone and buprenorphine, are actually opioids, and they have different pharmacologies. I'm not going to go into those, other than say methadone is what we call a full agonist. It activates the receptors in the brain, the same mu receptors that heroin and fentanyl do, and buprenorphine is a partial agonist. Why are these medications important in treating people with opioid use disorder? Well, they've been very, very well studied. Methadone is one of the most widely, there's more literature on methadone than almost any other medication. There's lots of literature on buprenorphine as well. And it does all of these things consistently. I could show you slides that show you treatment populations where the death rates and were just extremely high on people that are not on medicines. So basically, what it does is it increases retention in treatment. It decreases illicit opioid use. Those are the primary outcomes that we look for when we use these medicines. But we also know that it decreases rates of overdoses by up to 50%. It's protective against death when people use opioids. It improves social functioning, decreases the transmission of infectious diseases, including hepatitis C and HIV. And we see a decrease in criminal activity when people are stable on these medications. For those of you that are clinicians and have seen people do on these medicines and done well, you have seen this happen. I have had the opportunity to treat multiple patients in multiple settings, and it's really wonderful to see people that do well on these medicines. It's really a life changer. Unfortunately, in certain settings, people don't get to see people do well. So if you work in an emergency room, sometimes in a carceral setting, because you see people that are getting reincarcerated, those are the people that aren't doing well. But I see people whose lives have totally been changed by being on these medicines. Is being on the medicine in itself enough? No, I'm not saying that, but it's a critical component of stabilizing individuals' brain chemistry so they can do the other work that they need to do. And for each person, that's going to be a different thing. So they may have mental health issues. They have to deal with other recovery issues, the social determinants of health. Those things all need to be addressed. But when you're craving and you're illicit drugs, individuals are not able to focus on those other things. And we have multiple studies that show that people that are, we don't like to use the word detoxified anymore. We could use the word medically withdrawn from opioids, do very, very poorly. They're extremely high death rates, enormously high rates of relapse for those individuals. And here's just another slide that demonstrates some of the things that I was talking about. So compared to people receiving medications for opioid use disorder, untreated patients are just much more likely to die, either of all causes and of overdoses. Really striking numbers there. If you look at it, that's 1 year out. Medication-based treatment, only a small percentage of Americans with opioid use disorder who could benefit from this treatment are receiving it. I actually reviewed a study a couple of days ago from it was a cross-sectional study from 2019, which demonstrated that about 27% of individuals with opioid use disorder were on medications for opioid use disorder. We know that certain treatment programs don't offer medications for opioid use disorder. So it's a real issue. When you have a life-saving treatment that's recommended as the gold standard by every health organization in the world, it should be available for individuals. Whether they decide to take it is a choice that they will make with their doctors, but it should be available for them. Dr. Al Gupta, who is a new drug czar of the United States, published an article in the New England Journal of Medicine with some recommendations about the opioid crisis. Basically, these were his 5 of his recommendations, and you can see a lot of them were related to increasing access to medications for opioid use disorder. And if you look at the fourth one down, it was providing access to MOUD treatment to incarcerated individuals. So this is coming from the top levels of our government, our drug czar, that made these recommendations in an article that was actually published in one of the preeminent medical journals in the country, the New England Journal of Medicine. So again, I mentioned this, medication-based treatment is recommended treatment for opioid use disorders by all of the major health organizations, including our federal government. It's not a political issue either. The last administration wanted people to be on medications for opioid use disorder to increase access to it, and so does this administration. So it's not a Republican or Democratic thing. It's not an argument anymore. I mean, you might have people say there's a lot of stigma about these medicines for whatever reason, that you're addicted to another drug because it's an opioid, but there is no argument. This is the gold standard treatment that's recommended by every major health organization in the world. So people should have the opportunity to be on these medicines. One of the issues is there's a lack of availability of medication-based treatment in rural areas. So you can see in 2020, there was a study, only 45% of rural counties had a facility offering any MOUD. Only 9% of counties had a facility offering all 3 types of MOUD. 83% of individuals are at least 10 miles away from a facility. That might not seem like a lot, but it is. I mean, I work, we're going to talk about some of our work in Maryland, but I work in some counties where people just don't have transportation. They may ride tractors to the store or their bikes. To get 10 miles consistently is a problem. Because opioid use disorder was usually in the past was an urban issue, treatment programs grew up sort of not in, but around and in urban areas. So most methadone programs are in urban areas, I think 85 to 90%. And most buprenorphine providers are located in those areas as well. And I'll have some slides that show that. So you can see the driving times to treatment providers are significantly different for urban and rural areas. It's almost an hour to get to an OTP. And I know this from firsthand experience. I did some work in Garrett County. And for somebody in Garrett County, the closest opioid treatment program was in Cumberland, Maryland. And that, you're in the mountains and there's weather-related issue. As per the patients, and this was not my interpretation, it was just too far for them to get there regularly. And with methadone, you have to be there at least at certain times of treatment almost every day, especially at the early part of treatment. And if you're not doing as well. So it was really a barrier to being able to get into treatment. But this was the article I was talking about before from Dr. Gupta. Now we can just go to the next slide. So what are some of the issues? Well, a lot of individual clinicians, and I'm going to focus on prescribers here, which would be doctors or mid-level providers like nurse practitioners and PAs who can prescribe buprenorphine. There's been studies that say, why don't you use buprenorphine? And they say there's time issues. I worry that people are going to misuse these medications. I have a busy outpatient practice and I don't have the ability to provide the mental health and psychosocial support for these patients. And then for the people that weren't prescribing, they were just saying they didn't think there was a need for this. The community and my own practice partners don't believe in treating individuals with addictions in our practice. If I have a complicated case, what am I going to do? And a lack of confidence and sort of just a lack of administrative and infrastructure. And those are all, a lot of those are legitimate issues. If you're running a busy primary care practice and you have somebody come in that's high on opioids and benzodiazepines and they're sitting in your waiting room, you may not have the infrastructure to take care of them. And that's not something we're going to address in this talk, but those are some of the factors that have impacted the availability of these medicines in these areas. And just to take one step back, there are workforce issues, obviously, in rural areas that we don't see in some of the urban areas. A lack of providers, a lack of all types of healthcare practitioners. So in about 2018, we were not doing any kind of telemedicine. Probably about 2016, actually. We were taking care of our patients in Baltimore. We got approached by a friend of ours who ran a treatment program in Hagerstown, and he had an inpatient component to his program, and he lost his person that was providing buprenorphine treatment. And the gentleman had turned into his 80s and retired. And so they approached us about getting involved and helping them out. We obviously said we can't do it out there. We were not technologically advanced, but we had a telemedicine model within our department where we were doing child psychiatry through telemedicine to some rural areas. And we kind of connected with that group and said, hey, can we try this in Hagerstown? And so we developed a program with them, and we found that was very successful, that all the individuals in that program had counselors. They had, they were getting urine toxicology screening support there. We were just doing the buprenorphine providing. We had a really good IT group. We had great systems where we could really see and hear the patient well. So we started this program, and we've since then have kind of expanded our program into different areas of the state and different types of models. But the bottom line is we try to develop a relationship with a treatment center in the area of need of buprenorphine prescribers. We are not going into individuals' homes at this time. We're working through treatment programs. This really isn't, I think, that relevant for this discussion, but there's a law called the Ryan-Haight Act that regulates online prescribing. So we've figured out how to work around that by getting DEA certification for all of our programs. Again, all of our patients receiving buprenorphine by telemedicine are enrolled in a treatment program. We develop clear standard operating procedures focusing on clinical communication because that's a big issue. And we found that having a program coordinator on the other end really makes things easier. So some of the barriers we found were that we were treating patients that would kind of disappear. They get kicked out of the program maybe for smoking marijuana. And I had a doctor-patient relationship, so we felt like we needed to be involved in sort of the clinical decision-making. Not that we would determine or make all the decisions, but we would be engaged in that process. And again, the other thing, having a program coordinator at the other end was very helpful in sort of making sure that everybody got their prescriptions on time, if there were pharmacy issues. But we can talk more about that a little bit later if we have time, when we have time for questions. So right now, over the period of time, we've had relationships with rural health departments, different types of residential treatment programs, outpatient practices, county jails, and emergency department. So this is what I was talking about before. So this is a slide, and I don't have, I have it in the notes on my other PowerPoint, but there's clearly a health professional shortage in Maryland, and the dark areas are where the health shortages are. And it's clearly in the rural areas. You can see in the Washington, D.C. area, Baltimore metropolitan corridor, you don't see this, but the whole Eastern Shore, parts of Southern Maryland, and parts of Western Maryland are in the dark blue. So we have healthcare shortages. And all of you that work in these areas I'm sure see this. And this is just quickly talking about barriers to methadone treatment. We talked about that. There are just not many programs in those areas. There's also a shortage of psychiatrists across the U.S. This just kind of dovetails into the workforce issues. So there's just a lack of access to general behavioral health in some rural areas as well. Our current telemedicine programs, we're in 4 different spots. We're in the Wells House, our original program. We've been working with them for 7 or 8 years. We're also in the Caroline County Health Department. We have a very strong relationship with Caroline County. When we got there several years ago, we were the only, we started a telemedicine program. We were the only ones prescribing buprenorphine in the whole county. And we started a mobile unit there that I'm going to talk about quickly. And then the J team is our jail telemedicine programs, which I'm going to go into a little bit more in a minute. These are just some outcome studies from the Wells House, which showed that that opioid use was dramatically decreased. You can see that only 6% were testing positive for opioids at 3 months. This is through our telemedicine program. So we developed in Caroline County, what we found, we had a telemedicine program going directly into the health department. And what we found was even with working with the health department in Denton, there were a group of patients that couldn't make it to the health department. So we got funding through HRSA and the Behavioral Health Administration for Maryland to develop a mobile unit. And the mobile unit has a peer recovery specialist, a counselor, and a nurse on it, and it goes to small towns in Caroline County. It has a telemedicine capability as well, and we run clinics in all of these different counties. So right now, this is we're in Denton, Federalsburg, Greensboro, Ridgely in Caroline County. We're also now starting to work in Kent County. We park outside the Whitsett Center, which is in Chestertown, because they've had a lack of providers there. And we also go to St. Michael's. And it's just been amazing to me on an individual basis to see how busy we are. I actually run the clinic in Federalsburg on Monday afternoons, and I see patients pretty much all day, every day I'm there, and we have new people walking in. And if you think about this, this is one small county in Maryland, one small town in Maryland. If I'm that busy because I'm providing access, what does the rest of the state and what does the rest of the country look like? Here's some data on the program. We did a review in an article that got published in JAMA Open, but we saw, like, of the first 304 patients that we saw, the retention in treatment at 3 months was 60%. Now, this was not a placebo-controlled study. This was sort of a chart review back at the patients we were treating. We saw that opioid use was reduced significantly at 3 months, and patients had a significant reduction in travel time and distance. And we did a little bit of stigma work too, and just got some qualitative data. And patients said they really liked coming to the van because they didn't feel like they were being judged or stigmatized in that setting. And sometimes when they would go to a sort of the health department, they thought they stood out. Now, whether that's true or not, whether people were actually treating them that way or they felt sort of self-conscious walking in, I'm not sure, but they like going to the van. They feel like the team on the ground there is on their side and really want to help them. We run a low threshold model. We try not to kick people out of treatment and try to keep them there and work with them and helping them with their recovery and the social determinants of health. So correctional facilities, you can see that many correctional facilities do not offer MOUD around the country. This was a survey from the country. So you can see that it's not being utilized a lot in correctional facilities. And that's the team. Roger, the second from the left, when I'm looking at him, is sort of a critical component. He's a peer specialist who's also ex-military, knows all about machines. He runs the van, keeps it in working order. And right next to him is Christina, who is our counselor. So there are some challenges in doing, as a clinician, doing telework. I'm used to being the team leader, like in our programs. I'm more of consultant, although I do have some sway, but it's, I'm working in a different area with teams that have their own local culture, and I need to be respectful and adjust to that. We had to work a lot with the transition of patients that people would kind of, as I mentioned before, disappear for a variety of reasons. We wanted to make sure that even though they may not be suited for their program anymore, that they would be referred and engaged in treatment when they left. We had issues with our medical records, which we were able to address. Sometimes getting coordination with other providers in the area could be challenging because of the workforce issues, and just making sure that we had the scheduling down were all things that we had to work through over time and we've gotten better at. So we know that incarcerated individuals have a heightened risk of overdose and OUD. Over half of individuals that are incarcerated meet criteria for substance use disorder, approximately 15% for opioid use disorder, and a significant amount of deaths upon release involve opioid overdose. And there's one study that demonstrated, I think this was out of North Carolina, that the rates of overdose in the weeks after discharge, especially week 1 and 2, if individuals were to leave without any tolerance and they go back to using opioids with fentanyl in them, their risk of overdose death is extremely high. And you can see that, like week 1, you can see the overdose rates are just astronomical, and they start going down after that. So when somebody walks out of jail, not only has an opioid use disorder problem, they're at a really, really, really high risk of overdose. Couple jails. No, so I showed you the numbers before, that not many jails are offering this around the country, and medications for opioid use disorder. Here are a couple recent studies that come out. And again, I can get these, I had them in my little note box, but there was a study of incarcerated individuals released from the jails in New York from 2013 to 2017, and those that had received medications for opioid use disorder up to 3 days prior to release had an 80% reduction in overdose mortality risk. That's incredibly high. And then a recent study just came out of Massachusetts. You compared 2 groups of inmates post-release, and these were 2 different counties. I think one was maybe Franklin County in Massachusetts, 2 adjacent counties. One offered medications for opioid use disorder, the other one didn't. And those that were on buprenorphine upon release were approximately less than 30% likely to be reincarcerated. So that's like another goal. I know when I talk to the correctional officers and the wardens, they're not only interested in the overdose deaths, but what else is this going to do? And when I tell them, well, you're not going to see these guys over and over again, that's something that is very appealing to them as an outcome. So right now, we've developed telemedicine programs. I'm going to go a little bit into detail of how that came about, but we're currently in 6 different counties. All 5 of these programs are up and running. Queen Anne's County, we have a signed MOU, but we have not actually started to see patients. And we're actually talking to one other county right now about starting a program. So this is kind of where we're doing our work at this time. When we started this program, and I think it's a little bit later in the slide, we got a grant from the Fore Foundation. And this was before HB 116 was passed. I assume that everybody here knows all about it, HB 116, so I don't have to talk about that. But as of January 1st, 2023, all the jails in the state need to provide all 3 types of medications for opioid use disorder. Even before that law was passed, we were seeing that our patients tend to go to certain areas. Like they either come to a treatment program, they show up in emergency rooms, that they get incarcerated. Same guys, most of the people that get incarcerated are not bad criminals, or just people that got caught using drugs or possessing drugs because they had a drug habit. So we felt like it was important to try to treat them while they were in jail. We would see patients, for example, in the van that were doing great. They had six months sobriety, getting their lives together, and then they would get picked up on an old charge, get locked up, get pulled off their medicines, and go through withdrawal, have a, and then so it was really, really disruptive. So we got this grant. We tried to implement it in different jails. We had a few in mind, and I have to tell you, it was a struggle. There was a lot of barriers that were created, and we got very fortunate, actually. Gordon put me in touch with the Allegany County Detention Center, met a wonderful warden there. Dan Lasher was very interested in getting a program started, kind of opened his door to us. They have a wonderful nurse who I think is on the call here, Angel, and we were able to kind of really focus on developing a program that worked from the ground up and trying to figure out, what's going to work, what's not going to work. There was, it basically, Dan said, do what you need to do. And we had Angel, who was very invested in trying to make this work. So what we learned was you need the warden is the critical component. If he opens his door and makes you welcome, you have a much better chance of having things work. Health department needs to be involved because there's follow-up. They need to manage the non-clinician, the non-physicians. I'm doing the physician part, but if they're social workers or peer recovery specialists, Dan really doesn't have the capability or the expertise to supervise them. So the health departments need to be engaged, or some type of clinical entity on the outside. Then you need a jail medical team. Most of the jails in a well path, run by well path, but they're involved in giving the medicines and dispensing them. And then there's our team. And each jail, it's been of a different set of players and different way that we've had to implement depending on who was there. So first you got to get the detention center to buy in, the county to buy in that this is an important thing. I think HB 116 has helped because they have to buy in. So that we've gone to jails on the Eastern Shore, for example, Queen Anne's and Kent County, very small jails. They don't have a lot of medical space. There's a lot of construction going on. There's a lot of staffing issues. For example, in Kent County, wonderful Captain Wallace, who has almost had to take on a role of being nurse, counselor, and everything else. So each jail has been a little bit different. So what we've done, and we go to the next. So, but in Allegany County, we've been really fortunate. We've been able to develop standard operating procedures where we've tried to kind of create a standard of care, how we're going to triage patients, who's going to get seen at one time as they come through the jail, how we're going to do urines, how we're going to do our screening so we don't miss patients, how we're going to see them throughout their stay, how we're going to create the aftercare and linkage to care. I mean, I start talking about aftercare first day because in the jails, my experience has been you never know when somebody's going to leave. Some guys might say, I might be here for 6 months, and then he goes to court on Friday and he's gone. So these are things that we've learned that need to be addressed right away. We have treatment agreements, and we've had to learn how to deal with diversion, how to medicate a large group of individuals over a period of time, each day. So I think Allegany County right now is the biggest jail we're working in. It's I guess in Maryland probably more of a mid-size or a little less than mid-size, but it's probably got about 180 to 200 individuals. We're seeing about 35 patients a day are getting medicated. We run 2 clinics a week where we see people. Angel does all the screening. We talk about cases offline about whether we think they'd be appropriate, but she's the one that brings them, makes the decisions about the scheduling. And we meet periodically, all of us, to kind of discuss how the program's going, what can we do better. So we're trying to look at the data now, and I think we're in the process of coming up with some significant things. Like we're working with the medical examiner to see the patients we've seen if there've been any overdoses. Again, this is retrospective, looking at the data. So this is from Angel. She gave me these the other day. About half of our patients at Allegany are screening positive for opioid misuse. We treated about 319 patients. Some of these have been people that have come back to jail. Not only as always as a treatment failure. Sometimes people get transferred to DOC and then come back. So there's a variety of different reasons why people come back. We've had 283 patients treated and released, and we're seeing about 25 to 35 patients at a time. We do have a little bit of, we're getting more, but the only post-discharge data that we have is that they're out of the, 69 patients that I actually wrote a bridge prescription. So that's another role for me. Angel might call me and say, Joe Smith's being discharged today. He has an appointment in a week. So I'll call the pharmacy and write a prescription for him until he can get to his appointment. And of those 69 patients, 58 filled that initial prescription, which is about 84%. Our initial funding was through the Foundation for Opioid Response Efforts, the FOR grant. Right now, we're working with the detention centers. We have MOUs with the ones that we work with, and the majority of them have gotten money through OOCC grants. Some have actually gotten money through their own budgets to help support our program. And I think as we look at this in the future, hopefully the state will get on board, where they are on board, will continue to be on board to support this type of work. I know that in talking to Dan and other wardens, that money's an issue. They have a limited budget, and they need support to be able to pay for nursing time, correctional officer time, and doc time to make this program work. And then there is some talk about Medicaid waivers that will allow the jails to charge Medicaid for individuals receiving treatment for opioid use disorder. And a few states have already gotten these waivers. Sometimes they're only for the 30 days prior to discharge or the 60 days prior to discharge, but there's talk about whether this could be something of the future. And again, that's at a level on the federal level, and politics will probably determine whether that happens or not. So acceptability is an important factor, and we work really hard to work with the jails to educate their staff about why we're doing this. I can tell you sometimes when I walk into jails, I've had different types of receptions, to very positive to getting glares as I walk in. So we work hard to explain why we're doing this and the benefits of these programs. So you need buy-in from the leadership and the staff at all levels. It's critical to success, and this is nurturing and developing relationships over time. And so we determined this, and it was really interesting when we looked at Allegany County and we did the acceptability work. Not a lot of numbers, but the correctional officers were not as happy about the program as the administration and the medical staff. They completely disagreed that we would be running a program like this. We have some qualitative data, but I think the general sense we were enabling patients by giving them these medicines in jail. Next slide, and the next slides are pretty consistent with this. They didn't think that these medications worked and tended to be misused more than helpful, and they just had a more stigmatized view of this. And that's understandable. I mean, correctional officers are not health providers. They're there to help provide security in the jails. This type of program creates problems. You got to get people out, walk them around. People will divert their medicine. So these are things that they're not necessarily see it. They don't necessarily see this as part of their job. And so we need to kind of work on saying, well, if we get this guy on and he gets out of here, he may not come back, and it's better for the community. This is just a program that I'm part of, MAX, which is funded through the state. And the reason I put this on for people that are doing this type of work and have questions about using buprenorphine, we have a phone line that people can reach and get expert advice and consultation. We have a group of docs from Hopkins ourselves across the state that are addiction trained that can help providers that are doing this type of work.
Thank you so much. We've had a couple people that chimed in already. particularly with respect to the issue of funding for these medications. Howard Ashkin had posted, let's see, opioid restitution fund should be an important funding source. Hopefully there'll be some money from that coming forward. And Larry Stewart had indicated that Medicaid payment for Sublocade would certainly be a very valued change. There was a comment from Wesley Schreiber, we must reframe the lens with which we see MAT. And you touched upon some of those issues regarding understanding acceptability, knowledge, and potentially stigma.
I would like to say, just from the Sublocade issue, that's a great point. We feel that would be a great intervention. I know that Friends is doing some work there, but from a workload issue, if you could give a shot once a month versus having everybody walk from their cell every day, that would just be huge. It would also decrease the ability to divert medications as well. So I think it would be an ideal solution for the jails. Problem is it's expensive, and at this point, it's not an option. So it also would be a good transition to the community. If you get somebody a shot like a week before they're going to leave, then you'd have a little more time to sort of make sure that they would have that protection as they walk out the door.
Yeah, you mentioned the fact that you end up writing bridge prescriptions for a number of the patients as well.
We do that.
Yeah.
I mean, to me, it'd be a waste of time to treat them in jail if they weren't going to get the medicines when they walk out the door.
Eric, you mentioned that the work that you've been doing now regarding telemedicine really grew out of necessity in a particular county, and you've really expanded that both at the community health level as well as with the correctional facilities that you've partnered with. So it's really exciting. I was wondering if there was any specific telehealth delivery model component that had to change right away from what you anticipated in terms of this looking like to the way that you do it now. Or you said there are several things that have changed, but was there one that was a surprise?
Yeah, I think each setting was a little bit different. So I think for us, the initial shock for us is that there was just a different treatment philosophy in some of the treatment programs we were working with. So it was like, for us, using buprenorphine is to help keep people in treatment and stop opioid use. It really has nothing to do with marijuana use, so we were seeing people just getting discharged from treatment, which was disturbing to us. So having to and it wasn't an easy discussion all the time. I mean, I was accused of enabling patients. Well, do you want them to all smoke marijuana? I said, no, I didn't say that, but it's not a reason to kick them out of treatment because they are. It's something maybe now it's legal, so that's a whole nother issue. But so those were I think we needed to adjust on the fly and say, look, we don't run these programs, but we need to get in there and sort of have a philosophical discussion about treatment with MOUD and what we're trying to accomplish. And I think we know that, I've kind of painted a pretty picture that it's very helpful medicine, but we know that not everybody does well. And in fact, some people, and those are the patients that are difficult, the ones that are, doing okay, maybe they're not using opioids, but they're using cocaine every day or methamphetamine every day. These are non-jail people, obviously. So what do you do with them? And having that discussion with treatment programs, the initial feeling is let's kick them out of treatment, and trying to kind of work with that and say, well, how does that help the guy? It just pulls him off. It's medicines now. He's just going to die of an opioid overdose rather than those. I think that was the first issue that we had, and then we've also seen that we've had some pharmacy issues too. That the pharmacies, there's some pharmacies that don't want to carry it, that were suspicious of us because we had a DEA address that was in Baltimore and felt like we were, I'm not blaming them. They was just kind of, what are you doing out here writing prescriptions for our patients?
Well, you mentioned that it was really a different role in terms of what you were doing in treatment, where you were used to being the head and making those clinical decisions, and now it was a different kind of a partnership, it sounded like.
Yes, absolutely.
Yeah.
I do see another question about the
Yep.
chronic pain in rural areas. So I think it's just the type of work that's done there. There's a lot more physical labor, farm work, and things like that that causes these issues. So that's why there's more chronic pain. I mean, I can tell you there a lot of the people I see there started misusing opioids after either physical problems or an injury. I don't know if more people ride three-wheelers out there or dirt bikes, but we saw a lot of motor vehicle accidents, young guys that got hurt and then got, they maybe had a genetic vulnerability, got treated with opioids, and they were off to the races.
Mhm.
How long are my bridge prescriptions? Generally as long as needed, but it's generally not more than a week. I'm willing to do more than that if I need to, but I really need. What's important for me is that there's a plan in place. Where we got into trouble in a couple um, jails was that the outreach initially wasn't great, and I would get a call that day, say this guy's leaving, can you write a bridge? And I'd say sure. When's his appointment? Well, we don't really have one, and then I'd say, well, that's going to be a problem because what will happen is they'll keep calling back, and then I become the provider of record, and then it becomes easier for them to like just call me and get a prescription versus going to a treatment program. So we kind of, we needed to really work on that. I need an appointment, and then I'm willing to, if they can't get an appointment because there's none available for 3 weeks, so be it. But generally it's been a week. Angel's always the great. Like, give you an example. She'll write me an email. I need 5 days, and they have an appointment here. Go to this pharmacy, and generally I'll do an extra day or two just to make sure the person has enough. So we do what we need to do. I feel like I already have a relationship. It's not like I'm writing a prescription for somebody I don't know. It's somebody that I've been treating.
Yeah, you mentioned the importance of having both knowing the patient and how to do that, but also the relationships with your community partners, either the community health department or the community treatment provider, to really facilitate that transition. It sounds like in some ways you really rely on the jail staff to help with that
Absolutely.
release coordination process.
Yep, absolutely. And each county, it's different. Some health departments are more enthusiastic about being engaged, I should say. Some, individual nurses are more motivated to do this type of work. Others see it. Maybe it's just more work for them to do. And so you kind of got to adjust your style with the context of those four groups to make sure you get the best treatment program you can.
Well, and you mentioned that staffing is always, an issue, particularly in the correctional facilities that you've partnered with to try and expand their capacity, because there's only so much you can do via telemedicine on your end without things happening on the
Well,
ground.
yeah, and I'll give you another example. Kent County's had a lot of issues. I don't know if anybody's here from Kent County with staffing, and Captain Wallace was very creative. He got in touch with Mark Fishman, who runs a treatment program, and they're actually doing telemedicine counseling into that jail, which has been great. So it's at least an option, maybe. So it depends who you're working with. You meet some amazing people. You want to see this work.